Hello, everyone. My name is Terrell Parker. I am an Associate Program Manager at INMAC's Center to End Epidemics. Today, we're here to discuss a very important topic. We're here to discuss COVID 19's impact on the Navajo Nation and Indian country overall. In mid May, it was first reported that the Navajo Nation surpassed New York and New Jersey for the highest number per capita of coronavirus infection rate in the United States. This is a clear sign of the disproportionate impact that COVID 19 has had on the Navajo Nation. So, as we work to end the HIV epidemic, to end COVID 19 and other health inequities, NMAC understands that we can leave no community behind. And that's why this conversation is so important today. So today we have two really distinguished speakers who are here to share their experience both with COVID-19 and ending the HIV epidemic throughout Indian country. So first we have a presentation by Andrew Jolivet, Director of the Director of the Nation American and Indigenous Studies at the University of California, San Diego, and Haverkate, Richard Haverkate, National HIV/AIDS Director for the Indian Health Services. So without further ado, I'd like to introduce our first panelist, Andrew.
COVID-19, aka coronavirus, infection, no cure, weaponized, pandemic. But what about running face sickness, smallpox? Where were the masks? Hidden inside diseased blankets upon dead bodies. Don't touch me, don't touch that, you'll get it. They spread it. Why do they let them in? Said my Uber driver. Fear abounds on planes, in schools, in hospitals, all the places you should feel safe. But can you hear the cries of broken bones now turned to ash? Can you smell the rotten flesh of ancestors long since decimated? When we wake, what fears do we make? What refusals do we give? Do we even have a say? The greatest and the deadliest is body, is health. So where is the humanity in morning light upon dirt colored by blood, by children, dead wounds, forgotten diseases? Forget we are still here. We thrive. We will not be your pandemic, your plague, your fear, your climate disaster, your slave. Whip your own ass, break your own soul, steal your own land, disease your own children, and let us take our hands, stretch them across winds, across rivers, across lands unseen with our own eyes, and grab hands, squeezing out in drops of sweat every germ, every lie, every disease, every fear that we shall not exist, that our ancestors did not exist, that our children will not exist, that we shall not remain, but let us thrive, let us thrive, let us thrive. Respira, respira, respira. And inhale all that is good, all that is life, all that is human, stitched together by bone and flesh. Let us thrive, let us thrive, let us thrive. We are not your disease. Heweo, Yakoke, thank you. My name is Andrew Jolivet from the Attakapaw Ishak Nation of Southwest Louisiana, where I was former tribal historian. I come from the Tisikeep Opelousas Huron clan of the Sunrise people. I am speaking today from the traditional territory of the Kumeyaay people in San Diego, and give all honor and thanks to them, the stewards of this land who hold the original knowledge of their ancestors. I would also recognize the people of Yelamu, San Francisco, where I was born and raised, and thank them as well. So as was said in the introduction, there are devastating, right, numbers of COVID-19 cases in Indian country all across the U.S. Canada. I will say when we look at this as a global phenomenon and we look to places like Aotearoa, New Zealand, they've done an excellent job of actually containing the virus and really essentially have almost, no cases, I believe, at this point. Navajo and Hopi Nation, for example, are um, experiencing such high numbers. A lot of people are asking. I think we have to connect this to, as I talk, sort of indicated even in this poem, there is a long history of disease, infection, germs, right, from outside communities that began with colonization. This is not something new for our communities in that sense. And I think what's happening when you put people, if you think about HIV and AIDS, like I used to try to explain to people, diseases, if you look at the epidemiology or what we call the endemics, right, how disease becomes concentrated in particular areas, whether that be urban or rural, is when you have the same people, right, that are going to be constantly having contact over and over with each other in small areas. And so the gay community being, such a small percentage of the overall population, you would see so many more. It wasn't because gay people were necessarily, or queer people more promiscuous, like stereotypes said, or anything like that. That's not why. So there's not something inherently about gay folks that caused them to be infected for HIV. It was that they're in close proximity to one another, to other gay people. The same thing is true of the Navajo and Hopi. It is not that there is something inherently about Native and Indigenous peoples that we somehow are getting this disease more than others. It's actually about structural inequality, racism, the invisibility of many of our communities, the failure of this government. Even the governor of New Mexico had to speak out and say how the federal government response has been so weak in particularly the southwestern region of the United States, where the Navajo are located, the Dene. And so I was contacted through a colleague by the World Health Organization, maybe I want to say late March, early April. They were the World Health Organization trying to figure out ways, chief of staff to the deputy, the envoy for COVID, had reached out to me. And so I, tried, right, I think when we think about what are the responses that we give to this sort of ongoing history of colonial trauma and settler violence and terrorism over indigenous land and indigenous people. And so we've tried to gather a group of, researchers, medicine people to kind of respond to these issues. It's a really difficult time, right? Because the impact of this is not only that folks are being infected, right? Navajo has nearly 2,400 cases per 100,000 people, right? Which, as was said, is the highest rate of infection per capita in the US. And so what are we really doing about that? It's fine if we keep saying that, but tribes, when they passed the first bill to address COVID, there was a request for at least 20 billion in funding to go through to tribal communities. And at first, Republicans didn't want to give anything, right? But there is a trust responsibility that this government has to the self-determination, the sovereignty of tribes. And so eventually they settled on 8 billion. Well, even now, tribes are saying they still have not seen $1 of that money, right? And so there's been a failure again, and I think we need to look at that as the continuing dispossession of indigenous peoples and their land, our land. But in addition to that dispossession, we also need to think about the anti-Indian violence that is connected to that, the idea that we want to erase indigenous peoples from this country, right? Because to acknowledge what has and what continues to happen in terms of this colonial violence is to acknowledge also an international act of genocide that this country has never atoned for. And so I think if we really want to deal for COVID, COVID is exposed, right, long-standing health inequities, the comorbidities like diabetes, heart disease, lack of access, sort of the environmental, sort of racism that exists in, indigenous communities as well as Black communities for that matter, right? Lack of access to running water, electricity, high blood pressure, hypertension, shorter life expectancies, not even 50 years old in some cases, 55 years old. And so I think what we are seeing, though, I don't want to just sort of paint this dire thing either, though, because if you look at these sort of responses of Indian country, right? What we've seen, I've been on several of these talks, is that lots of folks in the community responded right away because we do know what this is like. It is hard when you can't. What do you do when you can't go have ceremony because you can't gather in groups of more than 10? What do you do when you don't have the funding for the mask or the PPE? And so we started a group after the World Health Organization contacted me on Facebook. It's a American Indian Resource and Response group, and so I'm gonna just share in the chat, and hopefully this works. If I can click it here properly, give me just a sec. Is some resources that folks can do if they want to help out or learn more. One of the links is for a GoFundMe for Navajo Hopi Relief Fund. One is another page on the Navajo and Hopi specifically and what can be kind of done to support them, and the others are resource groups. One is actually you can help out, folks, this is powwow season, and so are coming up. A lot of our vendors can't sell things, right? And so you can help support the vendors by visiting the virtual powwow vendor page. And so I've sent some links and hopefully that those go out. And so I just kind of want to wrap up to say that I think all of this for us as Native and Indigenous peoples and dealing with this, just like we had to deal with, other diseases, whether that was smallpox or malaria or HIV/AIDS or sort of other things that we can have continued to face, is that we also use our own knowledge systems, and we see our culture as our medicine, right? And so that allows us to have what I talk a lot about as cultural thrivance. How do we not always talk about Indigenous and Native peoples in this sort of traumatic way, right? Is how are we also doing more than just being a resilient people? How are we actually exhibiting our ability to thrive? And I think that's by centering our own knowledge systems and not allowing this government, right? So the other thing folks can do, right, I think, and this is, write your elected officials and ask them, what are you doing to respond to, particularly your federal officials, to this virus in Indian country and to issues of self-determination for Indigenous peoples. And I think the next presentation will talk a little bit more about, I think, something that is another challenge, and that is that most Native people live in urban areas now, 75–80% nearly. And so we have urban Indian health centers, but sometimes there is such a far distance to travel. And so another issue is access to adequate and proper health care. So with that, I will end, Hueo. Thank you.
Thank you so much, Andrew, for so much information. I got lots of great notes and some questions to ask you myself. So next, we would like to transition to Richard.
Thanks, Terrell. Thanks, Andrew, for that wonderful presentation. Folks, my name is Rick Haverkate. I'm currently the director of the HIV and hepatitis C program for the Indian Health Service. I'm an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians. And today I'm speaking to you from Fort Lauderdale, Florida, the traditional lands of the Seminole tribe. And the folks from NMAC asked me if I could talk a bit about how Indian Health Service is responding to the unique needs of COVID-19 as it relates to our folks living with HIV or needing access to biomedical interventions to prevent HIV. From the very beginning, IHS has been very proactive in reaching out to our communities in a variety of areas: behavioral health, diabetes, heart disease, smoking. We've formatted a lot of our training and outreach to the community to take into account the unique needs of COVID-19. But specifically with the National HIV Program, we wondered how people were accessing care and if there were any limitations or any issues around provision of care or people coming into our clinics. And I'm speaking specifically for those Indian Health Service clinics. I can't talk about individual tribally run programs or urban programs, There are folks who definitely can do that, but I'm talking today specifically about our Indian Health Service clinics. So we reached out to those 7 or 8 clinics around the country who see the most of or see the bulk of our folks living with HIV. And we surveyed them in early May and asked them to give us a little report on general access. So we found out that one program noted a likely increase in substance use among their HIV patient cohort, and another one of our clinics said that the initiation of PrEP services had decreased. The programs generally reported a minimal to moderate impact of COVID-19 on adherence to antiretroviral therapy, that therapy that keeps people at the undetectable viral load. But generally, they gauge the impact on health as moderate, but they cautioned us, reminding us that it's a little too early to tell. And this was just last month, but it was still a little bit early to tell on how much access to ART had decreased. One good thing, if there's ever a good thing, and I think we should always look for something good. So one of the silver linings of our current situation is that we've seen a dramatic increase in telemedicine. We've been trying to push telemedicine for quite some time. I personally think there's a really good, strong way forward in the world in general to access our patients via telemedicine. But our clinics are seeing in general about a 73% increase in antiretroviral therapy visits now that are done remotely or through telemedicine. One of our clinics, in fact, switched over to 100% of their folks living with HIV are now accessing their ART through telemedicine. But multiple programs said that they saw an overall reduction in service and contact with patients, and that had to do with the mail-only prescription refill. Some of our folks come to the clinic every 3 months or when necessary to pick up their prescriptions, but because folks are nervous about coming in close contact with other folks, or because some of our clinics said we're only seeing those who need urgent care, they've seen a decrease in the service and the contact and face-to-face contact with their patients. Another big thing is the reality that a lot of our technicians were pulled away from HIV activities to deal with COVID-19 responses. But in some, with the largest HIV patient cohorts in IHS overlapping with some of the areas hardest hit by COVID-19, and that happens to be mostly in the Southwest, it would appear that ART programs and patients have implemented an impressive set of compensatory strategies for delivery of care. So they've modified their programs as they moved along. We're used to doing that in Indian country. I think we're pretty adapted to change, and we jump in and adjust as needed. But still, the service and case management are suffering due to the need to devote resources to COVID-19 and to keep non-urgent patients away from the clinic to the extent possible. Overall, things are good, but there's room for improvement as always. In general, IHS is doing pretty well with our goals toward ending the HIV epidemic. Some recent data from the CDC let us know that there's been a 30% reduction in deaths due to an AIDS diagnosis in Indian country. I can't say that that's due, of course, to anything we've done in the last year, but I think over the last decade, tribal programs, IHS and urban programs have done a lot to bring HIV care to our communities, to implement biomedical interventions like PrEP, and to make sure that we're creating systems that reduce stigma, that promote the access to care, and getting people in that cascade of care from diagnosis to treatment. One major thing we're doing in training our physicians around the country and caregivers is implementing Project ECHO. It's one of those hub and spoke kind of programs where folks, for example, at the University of New Mexico, where the program ECHO, Project ECHO started, help Indian Health Service and tribal folks interact with each other via telephone and share patient caseloads. So there may be a physician in the Great Plains area who may be seeing a HIV case for the first time, and he or she can get on the phone with a group of other physicians from around the country and learn how to best care for that person. That saves the person living with HIV from traveling great distances to see a specialist. It empowers our local physicians to provide comprehensive HIV care. So we have programs designated just for HIV. We also have a program, ECHO, that's just for PrEP, so we can make sure that people have access to PrEP where they normally receive their healthcare services. And recently we started a ECHO specifically for trans and gender care. So we're making great strides even in the period of COVID. So I congratulate all those folks in the field who are working every day, boots on the ground, to provide the care, and promise I'll be helping to make sure you get the funds and resources necessary to make your work a success. So thank you for the time.
Thank you so much, Rick, for sharing your vast knowledge. It's so great to hear that despite COVID-19, Indian country is still progressing and moving forward with ending the epidemic efforts. That's really encouraging to hear. So next, I would like to turn it over to Chip for our Q&A section. Chip?
Hi, can you hear me?
Yes.
Okay, so we do have a few questions. And if anybody has any questions, please enter them into the chat box and we will get to them as they come in. And I think Ace may be joining us shortly to help
Yes.
out as well. So first question is for Andrew. It says, I'm from Colville tribes. Are the Hopi and Navajo contact tracing?
I believe they've started. I was on a panel with someone who is with the Dene Equality, and they were talking about that. I believe they have started to do some contact tracing. I think the thing with contact tracing, which it's helpful, but I also feel like I'm not sure if it changes the structure though. In place, like, right, it'll tell us who is maybe infected, and then folks can self quarantine. But then, what if you live with 3, 4, 5 other people? How do you quarantine from your family, and then where do folks go? And so this is what I was, kind of getting at, was sort of the structural issues that have plagued, many tribal communities for a long time. And so I think contact tracing has begun at Navajo and Hopi, as far as I know. And I think that I'm not sure if it'll be, how effective it may be. Obviously, it'll help to identify, but at the same time, we have to take care of those structural issues too. It's kind of similar, right, in a way that, we learning about folks once you're positive, right, that knowledge would make it possible. But I think the difference here is we're talking about something that's airborne, right? You don't need too much contact to pass COVID, as opposed to sexual contact or intravenous drug use or things like that with HIV.
Okay, great. And welcome Ace Robinson to the webinar. Thanks, Ace. Next question. Can you share the clinics that serve the majority of Indigenous people living with HIV? That may be a long list.
You're muted, Rick. I think.
Sorry, thank you. The majority of our folks living with HIV who are seeking care from Indian Health Service live in the Southwest. And the clinics they most often would visit would be the Phoenix Indian Medical Center, by far our largest clinic serving those living with HIV. They have, in fact, something called the HIV Center of Excellence with over 300 patients. They do an amazing job. They win awards every year that they're always embarrassed to accept, but because they surpass usually the 95% tile for those folks who are living with a viral suppression load, undetectable viral suppression load. So doing great work there. Next would probably be the Gallup Indian Medical Center. Those would be our two largest clinics with the biggest populations of American Indians living with HIV.
Rick?
Okay. Next question. Actually, it's a comment. It says cohabitation is always hard to deal with. Our tribe is offering hotel rooms. We've done very well with contact tracing.
I think
the last question received. So, I'm sorry. Go ahead.
No, I think that's, no, I was gonna say that's great. I think folks have talked about that. That's another way folks can support is, obviously either like food, hotels is a great thing if people have access to that, because folks can't get out the way that they normally might. So I think that's great that their tribe had some success with that.
Okay. At the moment, we don't have any more questions. So if folks have any questions, please enter them in the chat box. Are there any other topics we want to get into while we're waiting for additional questions?
Actually, I have a question for Andrew. I'm the liaison for our American Indian Alaska Native CAP at IMAC. And one question that we discussed, one topic that we discussed on our last call last week, was the problem of data collection for Native people during the COVID-19 pandemic. So can you talk about this, and specifically, have you been able to access mortality rate information for American Indians related to COVID-19?
So there are lots of studies. I'm working with a group of folks at the University of Washington in Seattle who, Karina Walters, and some others who also does actually great work on HIV/AIDS. But there is some more data, but the problem is, and Rick may know some of this too, because I think IHS was tracking some of this, had some of the data right by tribe and area. I had seen one indication of this, but the problem, your question, I think is an important one because it's not just for HIV/AIDS. I mean, or for COVID, or it's pretty much almost every health issue. Particularly, again, I will say like for urban areas where the majority of the population now lives. If they're even accessing an urban Indian health, center or not, or if they're going to a mainstream place, which many are probably going to like a county or other place where they are miscategorized. And so one of the major issues with this that folks had identified, so I'm not surprised it came up, was with the COVID, as a lot of people were being racially, miscategorized. Look at Rick and I, right? We look completely probably different, right? But both could be in that, counted in that category. And then you have every other sort of, configuration of sort of phenotype. But I think it's the last group people think about. I would actually often used to ask my students in my classes, oh, how many of you see, white students on campus? How many see black students, Asian, Latino, et cetera? And of course, they'd raise their hand, kind of look at me like, of course we see all these different groups, right? And then when I ask them about Native people, you might see like a couple hands or something here or there. And I think it's because, there is an expectation of what, Native people look like, or versus in a very different sort of fixed in time kind of way as compared to other groups, and people have a real lack of understanding. I think also one thing that's been happening that's kind of related to your question too, the anti-Asian violence around COVID, where people are, anyone who appears Asian, the people are, racially profiling, attacking, harassing, blaming them, right? Because we have a president who talks about, this is the Chinese virus, right? Very sort of racist language. That actually indigenous folks, Native people, right, who may also present, right, as Asian, are also being racially harassed and being told to ironically go back home or where they came from.
Yeah. Thank you, Andrew.
For some data that's more specific to just some Indian Health Service facilities, people can go to ihs.gov, and on our front page there, you see a COVID banner, so they can click. But again, that doesn't satisfy the question. I think, as Andrew and the questioner said, there's such a lack of data. So the data that's presented on ihs.gov, you'll see those just from those IHS facilities where we in fact know that they're qualified for IHS services. That means they are American Indian. But if they're being tested and treated outside of an IHS facility, their data is probably lost.
Thank you. So is there anything that we can do as allies to make sure that we're collecting better data for this community? What can we do? Now that we know what are the challenges, how can we address it? I know that's a pretty broad question.
Go ahead, Andrew. You have a question to answer?
I mean, I think I would just say, I mean, it's simple and it's not simple. I think a lot of folks, health, providers, things like that, they need to ask better questions and not make assumptions. I think we as a society in general need to do that. So people who want to support, I don't use the word ally because it's transactional. and it implies that if you do something, I do something for you, then you're going to do something for me later. I don't think that that's really what we want, right? I think we want people, at least in the context that I think about it, is it'd be nice if we thought of each other as relatives, and that this was talked about in the context of kinship and support, right? How do you support? We're all, human beings. People like to say that, but what does that even mean? But I think if folks really want to support, I think it is, going out and marching when there are issues related to Indian country and Native health. But I think it's also for each person to really educate themselves on what is happening too, and not have these stereotypes. I mean, there's so many stereotypes that people have or misunderstanding about, I think Native people now. And so people like to, take certain aspects of something of the culture and that part that may be more fun, right? They don't want to talk about the hard questions when those things come up, like if just one example might be the access pipeline, and that's another thing too. I mean, I think we're even seeing it in the moment, and we haven't said that. I think it's important to acknowledge what's happening in the country too, with sort of police, brutality and killings that are happening on the one hand in Black communities and in particular in Indigenous communities against missing, murdered Indigenous women. But I think, there's this other moment where people show up when there's the big event, but then when there isn't the big event that's in the media, I think folks also need to show up, right? When there's the small community gatherings and the small meetings to try to change policies that increase curriculum that actually talks about Native people in the present tense and not in the past.
I'd like to expand on that a little bit and just agreeing with everything that you said, Andrew, but it's really easy to stop and think there's no data. I don't like that there's not enough data, but there's no one specific to blame. There's no one agency to put that blame on. Data is a very tricky, dynamic subject, but you know what I can do is I can take responsibility to help change the minds of the people I elect to office, the people who work in my agencies, the people who make decisions about my community, and I can decide to answer the census. I can decide to answer questions based on race and ethnicity. I can decide to challenge when I see the square that just says other. I can challenge people that says, where's the square for American Indian? Where's the square for GLBTQ, Two-Spirit? So I think we all have a role to play, but I think it's a community effort, and I don't think there's any one entity saying that we don't want to collect data, that we don't want to produce data, we don't want to analyze data. I think it's a very difficult subject to answer with one simple question, but there's a lot of people interested in making sure that data gets better and better.
Thank you, Rick. Do you have any more questions?
We do. Next one, does ECHO presume that family practitioners can now take on the care of PLWH rather than needing HIV specialists?
Yes, most certainly. We are under the idea that we can provide the right kinds of tools for family practice physicians to treat and care for people living with HIV in their home clinic, the place where they have their regular doctor's visits. Those physicians, if they're willing, we can provide them with the tools necessary to provide the appropriate care.
Okay, next question. Excuse me. I hear that HIV surveillance from the IHS is distinct from state surveillance systems. Does the data merge at CDC? Is the distinct system underreporting Indians living with HIV in the states impacting resources and allocations?
We do rely on the CDC for most of our data on HIV. There are links definitely through the states because there are some laws set up, and they're different from every state. Not every single state reports to the CDC the same type of data with the same ability to dive down inside the data. But the data, we use data to do some of the allocations, but I don't think there's any data that says because we don't see any cases or enough cases in a single state that we're not going to support that state. At IHS, we advocate that we need funding for the entire country, for all of Indian country. We don't say that because the cases are higher in one state, they need more money. If I understood the question right, we do use data to allocate some of the funds, and we try to put it where we know That data shows us the cases are most prominent. For example, a lot of our funding does go to the Southwest because that's where we see the majority of our HIV cases, but those are people coming into IHS facilities. So we're not looking to CDC data to base that decision. We're looking at our own Indian Health Service data. We know the facts. We know those people are in fact qualified for IHS and they're in that clinic, and we know most of them reside in the Southwest. So that's why a lot of our funding goes to the Southwest. But on the other hand, when we're doing a broad reach for education or anti-stigma or to promote PrEP, we don't distinguish by any kind of numbers. We get that out broadly to the entire country.
Thank you.
So I have a couple of additional comments here. One is, and this is an acronym I'm not familiar with, so I will apologize. The OKTEC is working with funeral directors and universities to speak on this topic to address this issue in the Oklahoma area. They are who signed death certificates with race. Having a good working relationship with our county public health department has been super beneficial for our tribe. We sometimes have a harder time working with Indian Health as we are a tribal facility.
Mm-hmm. The TEC stands for Tribal Epidemiology Center. There's 12 of those around the country, each working to promote tracking of data, to respond to outbreaks, to promote better healthcare. But basically, their big job is to work with their individual tribes in that specific IHS area, make data accessible, produce community reports for individual tribes. So they're a great asset to Indian country. They're not run by the IHS like the person said in the chat box. They're operated by tribally run facilities. That one in Oklahoma definitely is one of our shining stars. They all are, but we work really closely with them, and they do some great work. They've been in the tribal epicenters have been around for about 30 years, and they're going strong. And the Minority HIV/AIDS Fund worked with me to specifically fund those tribal epicenters to work towards ending the HIV epidemic.
I did have one last question.
Yeah, we got one more here. Are you conducting HIV and HCV testing during COVID?
Yes, we are still promoting that, and the testing is still being done. We're working really hard to try to do self-testing or at-home testing. The Cherokee Nation is working to put into play a text for test, where people can send a text and the test kit could be mailed to them. But we're working with telemedicine, where we're limiting the interaction, the physical interaction that people would have to go through to have an HIV test. But we celebrated, or acknowledged, I should say, HCV testing day in May. I'm going to get this right. It wasn't necessarily hepatitis C, it was hepatitis testing day was in May. So we worked hard to promote that. We still need to make sure that we're testing people for hepatitis. And then this month, June 27th, is National HIV Testing Day. We're working really hard to keep up our testing in Indian country. We've done incredibly well over the last few years, and our numbers of testing go up and up and up. We've instituted universal testing for hepatitis C. So our policy is that everyone who over the age of 18 who comes into an Indian Health Service facility is offered a hepatitis C test at least once, and everyone between the ages of 13 and 63 is offered an HIV test at least once.
Rick, I have a question. I'm curious. I think you might have talked about this earlier, but I was also wondering about, I think in your presentation you might have talked about it, but maybe I was curious to hear a little bit more. You know, for folks who are already positive, right? Who need access, have you all seen anything with folks maybe being afraid to come out for either, you know, appointments or treatment or to get meds or anything like that? I'm just kind of curious.
Mm-hmm.
Yeah.
So when we surveyed those 7 or 8 largest facilities who do the most antiretroviral therapy, they said that they haven't seen a major decline. They've seen people exercising maybe some caution, so a moderate impact on COVID, where people being afraid to come into the clinics, but there hasn't been a big decrease in people coming in for the therapy, those folks living with HIV. We haven't surveyed the individuals, so I can't tell you any facts about what they're feeling or what they're experiencing on coming into an IHS clinic, but Clinic managers have told us they have not seen a drastic decline in patients coming in.
That's great. And I had a comment, since I see we have some time, to just one thing we hadn't really touched on, and I mean, and folks, if you want to chime in too, is sobriety. I think a lot of a huge other issue is people who are really super very isolated right now, that have maybe been in recovery, whether that's whatever the substances may be, whether it's alcohol or there's been a huge opioid crisis, for example, in Indian country, and other things. But people being in isolation to some extent too, and how that might also be a factor for recovery, right? I think a lot of people right early on in the HIV epidemic, right, was connected to these things, and they got, those who were able to get that wellness, that sobriety, are really struggling right now. So I think or potentially, right? And so I think it's important too to think about the mental health aspects of all this, and I hadn't heard us talk too much about that yet, so I just want to say I think another important factor in all this, and also for those who just generally for LGBT and Two-Spirit communities, whether there's the fears of COVID or folks, whether they're positive or not, maybe they're negative, but still, just what does that mean when maybe you are ostracized from your family and you're living alone during this pandemic, and can't have that. I was on a panel with Marlon Bailey, who looks at a lot of these issues in Black communities, and was talking a lot about this notion of pleasure and not having access to connect with human beings. And I think that's a really real thing right now that this is causing some issues for folks too. So I think the mental health and wellness, a lot of folks talking about what can we do around self-care in our communities, I think is really important. And that's why some of the Facebook groups I was mentioning, I think, are really important, because they are sites for folks to come together and have community. And it's been really powerful. Like that social distance power has something like, I don't know, 75,000 or maybe it's 100,000 now. I don't know, folks on there. And so when you're talking about a population of, 2 point, what is it? I don't know I haven't seen. Well, we're doing the census now for that reason, which we put a link in there for. So fill out the census if you have it. But 2.5, 2.6 million, maybe, as high as I've seen some where when you count in 2 or more races, where it could be 5 million or something. But, so it's a big deal to have that many people that quickly. I mean, Native folks were some of the first to have these virtual communities to kind of come together and support people's mental health and wellness.
Yeah. Andrew, did you put the plug in for the Two-Spirit Zoom support group meeting that happens every Wednesday and Friday?
No, I don't think I did put that one in yet. Yeah, and I was just talking to Elton, actually, I think talking about that group the other day. You know Elton, yeah?
Of course. Yeah. So
that'd be great.
On this call, you could, if you go to Facebook and search Two-Spirit, let's see. Well, Two-Spirit LGBTQ and Indigiqueer News. Marty Fixico, who runs that, supports this Two-Spirit Zoom support group meeting that happens every Wednesday and Friday at 6 p.m., 7 p.m. Eastern time, 4 p.m. Pacific time. I can put the link into the Zoom chat if you'd like me to.
Thank you.
Yeah, I was gonna look for it.
And Terrell, we do have one more question.
Okay.
Actually, we have two more questions now. It seems there are fewer American Indians using ADAP and Ryan White services. Does IHS access Ryan White resources?
Few of our clinics access Ryan White, and I don't really understand. It's not that we don't want to or that we can. It's a specialized system. I wish I could explain more about it, but we refer a lot of our people to Ryan White clinics, but there aren't necessarily Ryan White clinics located inside of an Indian healthcare facility. But we do encourage our folks to access Ryan White because of the incredible programming, and they provide amazing data for us. Even though we don't operate their clinics, I can call up the folks at HRSA and request a data spreadsheet, and they'll tell me by race and ethnicity how many American Indians they served and how many have reached that undetectable viral load. So they're great partners, great partners, but we just don't necessarily operate any of their programs.
Okay, next question, and Rick, this one's for you. What is going on with CHR funding? I've been a CHR for 27 years, and we were often the first called upon I know there's soon to be funding cuts to our program. Is there any hope the CHRs will be funded fully?
I can't speak on that. I wish I could. I don't have knowledge of that funding. I know that I personally support the CHR program. I'm in the midst of creating and releasing a special training just for CHRs to educate them to be PrEP navigators. And I get full support from our IHS leadership. I know there's support for the program. I cannot speak about the funding mechanism for that, but I know I can speak to the fact that that program is run out of the same office, the Office of Clinical and Preventive Services, and within my division at IHS. So they're like my sister brother program, but I don't know enough to tell you about future funding for that program.
Okay, at the moment, we have no further questions.
I believe Ace has a question, but I think you're muted, Ace. You may be muted.
There we go. Can you hear me now?
Yep.
Great. I have a quick question related to medical mistrust. So we already know about the unfortunate story history of the American government and the mistreatment of individuals when it comes to publicly funded federal research and publicly funded access to benefits from those research, like culturally competent services that should be given, doled out through our communities. So can you share, I think, some suggestions or some examples of best practices as it comes to bridging the mistrust that a lot of individuals have, which is well earned, unfortunately, by our clinical community, the mistrust that is given towards the clinical community and mistrust for the pharmaceutical community when it comes to accessing this care. So that goes from everything from telemedicine to your visits with your clinician to the treatment that they might prescribe the individual. What should we know, and what can we do to help mitigate mistrust of all those different media?
I had a colleague, or I have a colleague who was looking at this a while back, particularly around like pain management and medical adherence, so like taking drugs and looking at this. Dr. Michelle Jacob, she's been she was in Minnesota and now she's in Canada, but looking at this with Native communities specifically, and a lot of it has to do with doctors don't listen to Indian people, so people stop, and I think it's the same with Black folks and in particular Black women. I think there's a strong women's health period, right? That doctors not listening to what patients tell them or not recognizing the signs and symptoms they may have, and so people just would stop telling them. And I know in her research, they wouldn't believe when they were telling they had certain pain or pain levels, and so they just maybe stopped talking to them or even telling them when something was wrong. I think it's really important, though, in sort of a more global sort of picture of the question, is really kind of integrating sort of more integrative approaches to wellness that include traditional wellness practices, so that it's not always sort of the Western bio sort of medical kind of approach, because people don't trust that, and for good reason. And so I think there's also, we can't just pay attention to the physical, we also have to pay attention, I think, to the mental, or what one might call the spiritual. And so I think a lot of the centers that I've kind of worked with over years, like urban areas mostly, Native centers, there is always, right, that integration, like traditional or medicine people coming, but they also operate where they have sort of these traditional medical doctors too, I guess, from a more Western kind of approach. But really, it's about relationships. At the end of the day, I think that it really is about building relationships, taking time, but I think also for us in our communities to feel empowered to get the answers that we need, to not kind of be afraid of that. My mother died of breast cancer, and I think a big part of it was exactly that reason, right? Because she did not trust doctors. She got 4 or 5 different diagnoses, and she always said, "Oh, they keep trying to give me cancer. I don't have that." And so, whether folks choose to seek even treatment or even go see doctors, right? And the other big issue, even beyond that, is even the access. I mean, I think it's access, because if folks aren't going regularly, right, and doing sort of preventative things, a lot of people go to the doctor when something's wrong, and by then it may very well be too late. And so I think part of it is, I think community, wellness practices are really great. I think Cuba, for example, has what they call polyclinics, where you have a doctor in almost like every, like, neighborhood doctors who will go and check on people if they haven't seen them in like a couple of weeks. They go to their house, right? I know we have a huge population here, but I think just like people are having conversations about community policing models as opposed to institutional ones sponsored by the state, I think universal healthcare is great and everything, but just because everyone now has healthcare doesn't mean they're going to go to the doctor. Even if we do have universal or single payer, all these different debates, right? I think that's useless if we don't actually also change not just the structure, but the ideology behind what wellness means and how people access it.
I wanted to say too, if I have a minute or two to add, there's some good news coming from Indian country around this topic. We're working, I think I mentioned the Project ECHO that we're doing to train physicians how to better treat people with trans and gender issues. So it's been a great couple of weeks so far in our ECHOs, good participation. People are learning about hormone replacement therapy and a lot of special issues. So we've got physicians from Indian country on that call, learning from each other and hoping for more information. So again, they can provide that kind of care from their family practice. We're working with our Office of Information Technology to start including sexual orientation and gender identity on the patient record. We're working really hard to train our providers around Indian country to implement the ideas that we know work, where you create that inclusive environment. We're doing environmental scans in our patient waiting rooms. Are there things here that make people feel included? Are there gender neutral bathrooms? Are there signs on the wall that include images of LGBTQ and Two-Spirit? It's been very receptive. I have to say I'm very excited about the reception I've seen from our providers. And I think it's just going to take a little while, but there's some really good things happening to reduce that fear of people going into a clinic. We know from surveys that are done, like the transgender survey from 2015, where lots of people just do not feel comfortable going into a clinic. And they just won't go because they felt that stigma in the past. But I'm hoping those of us who identify as LGBTQ and Two-Spirit, again, take that responsibility upon ourselves and ask at the front desk or answer questions when they're asked about sexual orientation and gender identity. Talk to our doctors. We need to help create that safe space. I think people sometimes want to create that safe space. They're just as afraid as us and being offensive. So I think it's a group effort. So we're working hard to change and make things better.
That's exciting.
Thank you. And a quick follow-up question, maybe I missed this part before, but I was speaking with some people from the National Native HIV Network, and we were speaking about telemedicine and what needs to be done, and they were very clear and when they brought up conversations around the digital divide. And what is going to be, where we're talking about, we need to have more telemedicine, COVID-19, and before COVID-19, we were talking about however you're going to access people who are outside of American urban centers. And they spoke directly to the reality that, like, as you're moving into American modern focused healthcare settings, you're working at that level of distrust and something that might be different, and then you're adding on top of it a digital virtual experience, and then adding on top of it the most important piece: do you even have access to a digital virtual experience? So with all of those moving parts, there's quite a few moving parts. We would love to hear some suggestions of how we can better support individuals who, number one, don't have access, and if they do have access, that the trust issues are very low when it comes to getting culturally responsive care. Because I think what you were saying, like, it's one thing if you're going into a clinic and you think you're not going to get, you're not going to have a good experience, especially if you're Two-Spirit LGBTQ+. But another side is like, I'm not thinking I'm going to have a good experience if I'm having, like, how we're having a virtual Zoom experience.
Mm-hmm. Well, first of all, I don't think anything replaces that face-to-face encounter. So we promote that any day over telemedicine. I think in situations where people can't get into a clinic, or maybe they just don't have the ability to get to a clinic, if we can expand on the CHR program that someone brought up earlier, that's an incredible program that bridges that gap between clinics and people who don't have the ability or the time or the resources to come into a clinic. So that would be my second choice. If you can't get into a clinic, send a real person out to someone's house and do a home visit. But I think we have to fix that digital divide. I think the political will of getting internet connection, well, first of all, we should say electricity to a lot of our houses, making internet free for people, creating the technology where people don't have to own their own computer or their own telephone, but there could be community centers that are spaced in relation to where people actually live. I think there's a lot of moving parts that fit into that. I don't think that this digital means of communication is my favorite or anybody's favorite, especially for healthcare, but I think we'll improve on that over time and make the system has to work for us. We shouldn't work for the system.
Thank you.
Andrew, you're about to say
real quickly.
Yeah, I'd just echo that. I mean, I think that, and I sent a link that has some information for folks who want to read more about. It's from Arizona State, just a list of several kind of articles and things that kind of discuss the digital divide, the challenges to it, opportunities, what can be done. And yeah, I agree. I'm not sure it's the best, and in some ways, I think I would insert the age into this. I think with some younger folks, it is an interesting way to do that. I know at one point, Karina had a grant. I mentioned her earlier. Walters, I think, was looking at oh gosh, I won't remember it, but it was sort of like not gaming. Like I think they had created some kind of there were a couple things they had done, right? One of them was like for medical adherence, for monitoring, so people would get like alerts. One of the things I think was like you'd go into a club space and you'd get points for like sexual health practices or wellness practices. Did you choose the condom in the sex room or whatever? So you get a point as you go up these levels of this club. So I think there's also exciting ways in which people are trying to use digital technology to promote health and wellness. So I think that's important. So a lot of it also is not just the access question, but also where are the opportunities to make it something, particularly that young people, I think, would be really responsive to. Yeah, so I would just, only add that.
I got to put in a plug for wearenative.org, W-E, the letter R, native.org. It's operated through the Northwest Portland Area Indian Health Board. They do an amazing job of facilitating digital education, videos, interactive question and answers, but it's all designed for American Indian Alaska Native youth. But We Are Native, please check them out.
Thank you. Because I know when we have these conversations in community, especially with our actual youth, meaning the people who don't have any gray hair whatsoever, that if people say someone's 30 is a youth, I kind of roll my eyes. But when we're working with youth, trying to enhance their intimacy and pleasure, because it's not always going to be about love and finding a partner. Some people just want to have fun on a Friday. So being very realistic about how people are living their lives, and using a video game and being like, okay, you're going to, this is fun, this is fun, this is fun. Oh, you can integrate this technology, this prophylaxis, this treatment into your life, and you can still have the type of fun you want to have. So looking at that, making sure that the options of HIV prevention and treatment are fully available to everyone. Like some people will choose condom, some people will choose PrEP, some people will PEP, serosorting, or different safer sex practices. It's just making sure that everyone has that access. I know when some of the work that we were doing in the Phoenix area, the big thing that came up for youth was access to lubrication, and how important that was for individuals to make sure that they were going to have a good experience, because we're not going to have a conversation about any other tools if we didn't give them the baseline of saying, like, yes, you can have more enjoyable sexual experiences, and now we're going to introduce other options for you. So that was some of the feedback that we received full on from the folks who are outside of the Maricopa region.
Nice, thanks.
Okay, we have one last question. What are the actual case and death numbers for COVID-19 in the Navajo Nation? Is the trend upward, leveling, downward? Are there adequate facilities, resources, and expertise to provide standard of care treatment?
I've got those on my screen, unless you know them.
No, go ahead. I don't have them off the top of my head. I pulled it earlier, but yeah, I don't think it's slowed per se, but yeah, I know. Is it 4,000? I'm trying to remember how many cases. No.
Positive COVID cases as of May 31st were 5,250. And it does not appear to be slowing yet. There has been a lot of tests. They're doing more tests per capita in Navajo than any place else in the country. So good news there. There's been 25,000 plus negative results. Total tests administered have been over 30,000. There's been 241 deaths, and that was as of May 30th. But people can go to the Navajo Nation. I'll put this link on there too for the latest updates on COVID in Navajo. I'll put it in the chat box. But their tribal epicenter, we spoke of tribal epicenters earlier, the TEC, they're doing some great work in keeping those stats current for us.
Thank you, Rick.
I want to thank both of you guys for sharing part of your afternoon for this very important topic. I think the comorbidity of HIV and COVID-19 as impacting Indian country is so present and unassailable. Is like it's right there in your face. There's no way you can push this to the wayside. And we need to make sure that we're building those bridges and building those partnerships because there's no community that is going to succeed in this without having the full support of other communities, and not just the highly impacted communities, but also the communities that are less impacted. So education is the key, and empathy, and really doing the hard work to get us to that finish line where health equity is no longer just a conversation we have in public health circles, but something that we speak about at the dining room table, in the pool hall, or on the street corner.
Agreed.
Do you guys want to say anything, some final words, some parting words of wisdom?
I did want to say that I just shared a link in listening to the last comments. The Pre-Indigenous International HIV/AIDS conference is happening virtually. It was to happen in San Francisco and Oakland due to COVID, though it's going to be virtual. So I just put the link in there for folks who want to register and learn more about HIV/AIDS in Indigenous communities, not just in the U.S. but globally. That'd be a opportunity to do that. And I guess I would just say is, thank you for having us and raising awareness, because you had asked that question, like, what can folks do? This is one of the things folks can do, is sort of bringing greater sort of visibility to these issues, because oftentimes when we talk about issues of race, ethnicity in the country, whether it's related to health or anything else, often Native people are kind of an afterthought. And so I think the more visibility we can place on the original people of the land we're all standing on, and not just sort of like I did the land acknowledgement of where I'm at, but that only goes so far too, right? There's also like, okay, enough with just land acknowledgements. That doesn't mean anything if we're not actually going to do something to help support folks in protecting that land that people are still living on. So so yeah, thank you for having us.
Thank you, Andrew. I'll what he said.
Great.
Terrell?
Thank you all for joining today's webinar. Joining us. We hope you enjoyed the webinar. We hope you gained a lot of information, and we hope that more than anything, you support the Navajo Nation and Indian country, and we take action. So thank you all for joining us.
Thank you, Rich.
Be well.
Great weekend.